be pertinent to today's discussion, and I've served on Gilead's advisory council in the past. Next slide. No other disclosures here. Next slide. So just our learning objectives, we're going to review through our OSU HIV telemedicine program and show you how some of this telemedicine equipment that we're utilizing through the program is utilized in a telehealth visit. I have actually an example of a patient case of how we were able to utilize that equipment, and I'll show you some of the equipment through slides. And also we're going to review through what are some of the challenges of telehealth and what are the pros and cons of a telemedicine program, particularly ours, and how we've overcome some of those challenges. So this is our clinic here. For those of you who have not seen it before, we have a Walgreens specialty pharmacy on our bottom floor. We're located on the 3rd floor, our internal medicine clinic, as well as our internal medicine specialty services, which is our Ryan White funded HIV clinic. We are a little over 1,300 patients currently, but have treated over 3,000 patients, and we cover the eastern half of the state. We have been here since September of 1996. Not in this particular building, but we have been in existence since then. These are our service areas. So in orange, on the eastern half of the state is our territory. That is our coverage, but as you can see, even in that eastern half, there can still be areas where patients are having to travel quite a distance, 2 to 2.5 hours in some instances, even up to 3 hours, to be able to get to us here in Tulsa. On the red side, you see OU, and that's OU Infectious Disease Institute, IDI clinic there in Oklahoma City, and they're a little over 1,600 patients covering the western half of the state. So together, we're treating patients here in Oklahoma with HIV. Our state has a little over 5,000 patients diagnosed with HIV, but we're still missing patients that haven't been diagnosed, and that is part of the funding for ending the HIV epidemic in Oklahoma currently, where this has been expanded, where there's been new testing sites through FQHCs that have now been initiated, as well as providers writing more for PrEP or pre-exposure prophylaxis. So we're trying to expand services, expand testing so that we can get patients then linked into care. And I also want to mention that we have a new grant that's recently funded for a telemedicine program for Rapid Start in rural areas. So we're going to be expanding this telemedicine program that I'm going to talk about today and be able to offer rapid start of medications through this telemedicine program to rural Oklahoma, particularly in McAllister and Poto, which is where we do telemedicine currently. Next slide. So again here, remember it's the eastern half of the state mostly that we are covering. And so the two circled there, McAllister and Poto, McAllister being a couple hours and 2.5 hours for Poto for those patients that would need to travel to our clinic to get care. So several years ago, telemedicine was started, and I have taken over the telemedicine program. It's probably been 2 or 3 years now to be able to bring care to those sites. And we're hoping to expand that further. At some point, we would like to still include the upper area of Oklahoma, the upper eastern corner there, and hopefully be able to initiate either a Veneta or Miami site. But these are the two locations currently. So what takes place is actually we've had a telemedicine bus in the past that we have one of the nurses from the clinic as well as one of our IT guys. Both of them go together on the bus to these rural locations, McAllister and Poto. And I'm able to have contact with them through Zoom. And so I am able to be here in Tulsa in my office and still be able to visualize and see these patients in McAllister and Poto. We've slowly transitioned from the telemedicine bus, and I'll talk a little bit more about that in a bit, but using secure locations in these sites attached to hospital space so that we can actually have a little bit better connection than on the telemedicine bus. So we've actually been able to secure sites in some of these locations so that we can actually see these patients in a local building, so we don't always have to utilize the bus, but we have the capability of using the bus as well. Next slide. So I just want to start out with a patient case, and then I'm going to show you some of the equipment and how we were able to utilize it with this patient. But this particular patient, 55-year-old male, HIV positive, living in Poto, Oklahoma, and the biggest barrier for him to staying in care was transportation. Many times it was either that he didn't have access to a car or had car, but maybe didn't have the means to have money to put gas in the car to be able to travel to Tulsa. And so telemedicine became an integral part of his care. As long as he was able to make the telemedicine visits, we were able to refill prescriptions, do labs in a lab locally in Poto, and get those labs so that I can review them and be able to conduct a telemedicine visit. So his biggest barrier was transport, and so we did then initiate him into our telemedicine program. Yeah, he had been on Raytaz or atazanavir, Norvir or ritonavir, and Descovir, tenofovir, elafenamide with anthracytamine as his regimen. CD4 300 viral load undetectable on that particular visit. I believe this particular visit was a couple of years ago when I had seen him. He had complained at cough at that visit, but had recently seen an urgent care and had received azithromycin and Flonase the day prior to the telemedicine visit. And he then also says, well, by the way, I have this itchy spot on my right leg. Can you take a look at that and tell me what's going on? So how did we utilize telemedicine in this visit? We were easily able to conduct a telemedicine visit. Already had my nurse who had sent orders for him to get labs, and we had those lab results, then obtained those, scanned them into the chart, so I'm able to review them prior to this telemedicine appointment. He was able to get the labs in Poto, so we didn't have to travel outside of Poto to obtain that, and we were easily able to get results by a fax. His prescriptions on the day of the appointment, he's undetectable. I'm able to refill his prescriptions, send them to a local pharmacy, and he's able to pick them up without any problems. If he is part of our drug assistance program with the state, that pharmacy is in Oklahoma City, but they mail the prescriptions out. So again, he's able to utilize that if needed. We also are able to talk about the interaction with his medications, the interaction with his ritonavir or Norvir and the Flonase. So we're able to discuss that and make just a minor adjustment to the dosing on this Flonase all through the visit. But he also said he'd had a cough and was on azithromycin. Well, I'm able to utilize a stethoscope program and use a stethoscope through telemedicine to be able to listen to his lungs. So I'm going to show you how we do that. His lungs were clear on that particular visit. But then I also wanted to take a look at that itchy spot on his leg. And just looking on the camera, it's a little bit hard for me to see what's going on. So we're able to utilize our dermoscope. And on the other end, my nurse Kathy is able to put the dermoscope closer to the patient's rash. And we were actually able to diagnose tinea corporis that day and able to easily treat that through a telemedicine visit. So we did a lot of stuff on this telemedicine visit, a little bit more than we could do just with a virtual visit as we're doing now, utilizing things such as Zoom or Doxy or other platforms. We do utilize Zoom for our platform with telemedicine, but with utilizing a stethoscope and some of these other scopes, get a little bit more of a physical exam. Remember, there are still limitations, and I'll go over that here in a little bit, but we'll go ahead and move on to the next slide. So this is our telemedicine bus, and I'm going to show you in the next few slides just kind of what it looks like on the inside as well. But basically, we're utilizing this like the patient room. The waiting room is out, and patients are using their own cars as the waiting room. When it's their turn, then they come onto the bus. They're called in to get their vitals and do their check-in, and then we go from there. Next slide. This is our check-in desk on the bus. So when it's their turn, they're able to come in, check in, and my nurse Kathy is able to take their vital signs. She's able to access our electronic medical record, put it into Epic so that I can visualize it on my end here in Tulsa. And she is also able to do a depression screening. So we do a patient health questionnaire. If they need any immunizations, particularly during flu season, we will oftentimes give flu vaccines on the bus as well. She's able to get a verbal, or actually a written consent now. We used to do a verbal consent previously, but now have a written consent for a telemedicine program. They're easily able to sign that and update their paperwork with her at the same time. And then she also does their medication reconciliation, which she puts into Epic as well. Next slide. And this is our patient room. So we have all of our equipment here. Kathy has the scopes as well as the stethoscope on her end, and then is able to project that information to me here in Tulsa through the screen and through the program. Next slide. So these are our scopes, and this is what we utilize. And probably the most frequently used one is just the general scope, and I'll use that to usually look in their mouth. I like to do a good oral exam on most or all of my patients just to make sure there's no oral candidiasis or thrush. And so I can easily do that. Sometimes, you know, we're doing a lot of virtual visits these days, and sometimes I can get a good visualization. Just depends on their camera quality. So sometimes an oral exam is still able to be done through that, but sometimes it's not, and this gives me a little bit better picture through these scopes. There's also an ophthalmoscope attachment. There's a dermoscope attachment as we used for the rash. And then there's also an attachment to otoscope so that I can take a look in their ears. Next slide. And so this is just a visualization. Now we don't see kids, but this was a good image, so I thought it would be a good representation of what we do here. But basically, Kathy is able to put this otoscope into the patient's ear, and then it will project for her onto the scope on the scope there, as you can see. But then she can project that image onto the screen, which is what I'm able to visualize. Also, it takes a little bit of education. So remember, especially when looking in ears, is we go through medical school, you know, we're pulling the eardrum back so we get good extension and straightening out of that eardrum. So it does require education of our staff when we're utilizing this kind of equipment. Kathy's very familiar with it as she's done telemedicine for some time with me, but sometimes if we have somebody substituting in, it just takes a little bit of education, making sure they know how to utilize these scopes and how to project the image. Next slide. This one's just showing the general scope, looking in the patient's mouth, and then what we're able to see there on the computer screen. Next slide. And then this one's this is actually our stethoscope program. So we used to use a different stethoscope program. It required a lot of updates and seemed like every time we turned it on, it was requiring another update. Now I actually use this ThinkLabs app. And the app's on my phone. So on Kathy's end, the nurse, she will utilize a stethoscope to the patient's chest, and they're able to hear the sound. It will project to me onto the app through my headphones. I can then auscultate heart and lung sounds. If we have any connectivity issues, which oftentimes in rural Oklahoma can be an issue, if that does happen, they can actually pre-record the sound and send it to me as a file. They just text it over to me and I'm able to hear it right then. So it gets around the connectivity issues sometimes we do have in rural areas. It's an excellent program, has worked really well. The sound is excellent, so heart and lung sounds come through very clearly. Next slide. And as we went over it, usually pretty minimal staff. Now, the thing that we do want to make sure is that we have a good number of patients scheduled for that day, because we are sending staff out to these facilities. So usually, like we talked about, I'll have my nurse do all those things in the rooming process. We have our driver of the telemedicine bus. So if we're actually taking the bus out, it's Chad. He's our telemedicine bus driver. He has the license for the bus, but he's also our IT. So if we have any technical issues, he's able to assist us with that. And then it requires the physician on my end. I do the telemedicine program here, and I'm able to, as long as I'm able to connect into Zoom, I use our current EMR, so documentation is the same as if I was seeing a patient here in the office, and have to be familiar with the coding for telemedicine. The nurse is familiar with documentation and electronic medical record as well, since she is familiar with our electronic medical record here, there's no changes there. Next slide. Some of the challenges that we've incurred. So with the bus came along, you know, whether there was weather or mechanical issues for the bus, and sometimes, especially in the winter months, we would have issues. So we started looking for more concrete locations that we could actually have building space in Poto as well as McAllister. And so we've actually been able to overcome that challenge with that. So we're utilizing the bus a little less and actually using these concrete locations, and we found connectivity has improved drastically with that. Remember, if you are utilizing the bus, maintenance and fuel costs, Wi-Fi and stethoscope connectivity can be an issue if we're having trouble with connection. And so things such as all of us have kind of like different cell phone providers so that we can have some type of connectivity through that. If system goes down, then we're at least able to connect through our phones. We also have tried hotspots, etc., to try to improve on the connectivity. And then previously, it was always the parking of the bus. If there were trees or a building in the way, that could have influenced the connectivity. Using concrete building space has also gotten past that issue. Software updates, as long as we're aware of that, but we've taken care of that issue for the most part with our new stethoscope app. Inexperienced staff. So right now, my current staff is very familiar with our equipment, but anytime we have new staff, it does require a little bit of education. Cancellation of appointments or no-shows. So we try to verify these appointments as much as possible in terms of labs as well as their actual appointment. Because remember, we don't want to go out to just see 2 patients. We want to have a full schedule if we're sending 2 staff members. And so that's another thing that we've looked at. And with our new grant for telemedicine and rapid start of antiretrovirals in these rural areas, we're actually looking at contracting staff in those areas so we don't have to send our own staff out to be able to conduct these appointments. And yes, it's going to take some education from that part, making sure they're familiar with the equipment and the electronic medical record, but that's what we're working on currently to make improvements. A secure site and location for the bus as well as storage of the bus has been something that we've done, and we usually store it over at OSU. Referrals in rural areas, we've got to think about these things, right? We're used to doing referrals, and most of the time we're referring in Tulsa, but patients don't want to drive 2.5 hours to see a specialist sometimes, and they want to see somebody closer to them. So that's something that I've become familiar with. For example, I'm doing telemedicine in Poto tomorrow. I know that Fort Smith is closer for them than for them to come all the way to Tulsa, and sometimes we may not have the referral that we need in Poto itself. So just being familiar with the areas. Remember to take into account time spent driving. So for my staff, when the nurse and IT, they go out, they're leaving 2 to 2.5 hours prior to our session that starts at 8:30. And then when we end at 11:30 or 12, then they need that time to drive back. So taking those types of things into consideration so that we can have efficient use of our staff. Next slide. So I think as we went through those, we talked about how we've overcome some of those challenges. Some of the other things that we're looking at, we've already contracted with hospitals for building space, so we don't have to use the bus as much, so that it gets rid of some of those challenges that we had as stated above. But also looking at making improvements, starting surveys for our telemedicine program, and then opening a new location. These are all some things that we're doing to improve the program. Next slide. Pros and cons: it's convenient, it's affordable, and it does save time and transport. But remember, the connectivity issues can be on the downside, and working through those. Lots of personal touch. So, I mean, you guys know we're doing virtual visits right now, and it's just not the same as seeing a patient in the office. Yes, it does sometimes lose that personal touch, but if it makes the difference between a patient staying in care or not, it can be a big difference for a patient, like the patient case we presented, where he may not have been able to stay in care if we didn't have this available to him because of the transportation barrier. Remember, it can be difficult for complicated cases. So I've had a complicated case before where I've told the patient, I need to see you in the office. And the hardest part is, there's a lot of mental health and depression in rural Oklahoma, particularly in patients with HIV. And so I've had on more than one occasion a patient tell me they were suicidal on a telehealth visit. And that loss of personal touch is a big difference there. But at the same time, we were still able to reach that patient and get them help and get them assistance, get them care. So even knowing the resources for things like mental health in those rural areas is so important. But if we're able to bridge that gap, I've even had my therapist reach out to patients that are in rural Oklahoma, and they were able to do it through a telephone call. And sometimes just doing a counseling session, even that way, was enough to reach a patient. So always keep that in mind. And then remember, it's a limited physical exam. So even though I'm able to listen to heart, listen to the lungs, maybe look in their ears, look in their mouth, I still can't do things like an abdominal exam, or if they're having back pain, to really do a musculoskeletal exam without seeing them in person. So there's still limitations, but it's just an additional or added benefit, something else that we can do to get a patient care. And remember, keeping them in care and keeping them undetectable is our ultimate goal with HIV. Next slide. Just wanted to pop this up there. This is something that we've been working on as a flow chart for our patients. So again, improving our telehealth program is just who has what responsibilities: our front desk, our nursing staff, our physician. There's basically a part of the flow chart for everyone for telemedicine to run smoothly. So if you're thinking about starting telehealth or doing telehealth visits, it's important to make sure that all of your staff that's going to be involved in it is they know their duties. And this is important because we're about to actually start our telehealth or telemedicine program for test and treat, or rapid start, and we'll be extending that to McAllister and Potos. So if there's a newly diagnosed patient in one of those areas, that we'll be able to get them on medication right away. And usually we're trying to get them on medication within 7 to 14 days. I really like to keep it under a week if possible, and we'll be able to bring that to rural Oklahoma. And so it was important to have a flow chart or process in place as we launch this new program for our new funding. Next slide. And that's just the rest of that flow chart there. Next slide. Okay, perfect. So I just wanted to say thanks to my telemedicine staff. They do a great job, and it's just something very unique. This year, I was actually able to present our telemedicine program at our national Ryan White conference that was virtual this year. And so a lot of great comments about what we're doing. We're very unique in what we're doing here, but if we can share these experiences with other places, because there's certainly other states that are rural like we are, and going through the process and talking about this and doing this, found out, Alaska does something very similar, but they've been doing it for years out of need because everything is so spread out in Alaska that that was the only way that they could actually bring care to some of their patients. So it's just interesting what people are doing in different places, and just being able to share ideas and basically continue doing these things and spreading word and making changes, particularly as we talk about ending the HIV epidemic. I think that was my last slide. Just wanted to see if anybody has any questions, comments. Oh, and I do see another spoke that is here. And I just wanted to make sure to take the time to be able to introduce. See a James Ritz. Are you able to unmute and introduce yourself?
Dr. Ritz in family practice in Broken Arrow.
Yes, absolutely. Thank you so much for joining us today. I hope you were able to listen in on most of that didactic. Glad that you joined us. Wanted to see if anybody else had any questions or comments in regards to anything that we presented today, any of the didactics, anything about the telemedicine program. Well, great. Just to our primary care physicians out there, just wanted to make sure that all of you know we do have our Rapid Start program that we do through our OSU Specialty Services. So if you are testing patients for HIV and have one that tests positive, please be sure to call our